Thanks. I was actually going to start with that because after the case last month, I was able to get the ME report and it showed absolutely nothing on there. So I discussed it with Dr. Ruiz after he was on the conference, and we think it was probably an air embolism then, due to the fact that the medical report said nothing about, any sort of clot lodged anywhere.
Thank you, Doctor. Dr. Antok, any question or any comment?
Yeah, no, I mean, it's really very, it's an unusual case, really.
Yeah.
To have such global anoxia to the brain and no obvious source, and I guess all of the toxicology was negative, and it's very, very odd.
I know, it's really odd. So I talked with Dr. Ruiz about it, and he was like, it must have been an air embolism if there was nothing else noted on the pathology report.
Yeah. And the pathologist, can they see, are there any findings in the case of air embolism, or they can't confirm that if that occurred? Or
to my knowledge, there's no way to really confirm that on pathology.
I mean, I looked to confirm.
I looked for signs of ischemia in any of the organs, because of course they looked through all of the organs, because we were discussing the possible renal infarcts on the CT scan, but they didn't find anything.
So the kidney, the right kidney, was normal. Is that it?
Yeah.
There was no infarct. Yeah.
Correct.
Right. But
yeah.
Right. Also, if it was embolic or thrombotic, you would expect the brain to look like the kidney, where it'd be a wedge, one area in the distribution of a feeding vessel, and it was just very, very odd, and geez. And then just reviewing the records, nothing happened in no structural problem happened in the ICU, like oxygen turned, but the alarm would have gone off if that happened.
Right. Yeah. No.
Yeah, that would have been. Yeah.
Right. Because
right. So it's very.
Yeah. Because that's a good question. That's obviously the time in which we weren't, intimately involved in the care of the patient. But before the last presentation, I reviewed all the vitals. I reviewed everything from the ICU to see if there was any sign that was, going to occur. And I didn't find anything.
Yeah. But the monitoring is so good now. They would have shown hypoxia, and that's really something.
Yeah. Thank you for bringing that up. All right. So good afternoon, everyone. I think most of you know me. My name is Jen Lobb. I'm one of the trauma fellows here. And I've had a run of interesting cases with penetrating chest injury. So this will be my next penetrating chest injury case I'm presenting, and I have another one in December. So, but this is management of a chest injury with a retained foreign body. That is the title. And then some learning objectives. So we're going to just do an overview of the management of penetrating chest trauma, review some indications for operative intervention, and review some different operative approaches that we can use. So this was another gentleman at Jackson South. It was a 48-year-old gentleman. He was brought to Jackson South ER. This was on September 15th. The report was that he'd had multiple stab wounds to the chest and back, and that he had bilateral needle decompression performed in the field. Actually, this gentleman came in early in the morning, right before Dr. Poost and I started our shift. But I'll just include the things from the trauma team who evaluated him. He had an intact airway. He had bilateral needle catheters in place. He had bilateral breath sounds. You can see that he was hypertensive and he wasn't tachycardic. He had a GCS of 15, so totally stable patient. On exposure, he had a 1.5 centimeter laceration to the left upper back, and then one to the right back, and then also one to the left upper arm, and then a 2 centimeter laceration to the left chest and the axilla. He had initial chest x-ray on presentation. You can see here, oh, sorry. You can see these, you can see the faint outline of the needles that were placed in the field. So you have a patient that comes in with a reported stab wound to the chest, axilla, totally hemodynamically stable, bilateral needle decompression. So the question is for the group, what you would do next with just these findings that we have. I wanted to poll the group and see what you think.
Yeah, Jennifer, can you put the chest X-ray back up again
Absolutely.
and maybe ask the groups if they see anything else abnormal on the chest X-ray
Mm-hmm.
beside the catheters?
Okay. Dr. Frisbee,
What?
would you like to make any comment?
Oh, sorry. He's completely stable?
Completely stable.
Well,
The question about the chest X-ray. Hey, Dr.
There's
Frisbee, good to see you.
There's
First-
something there additional that I didn't really point out, but
well, I don't like to play gotcha, so I'll just say I don't see it. If it's there, I probably will, but that looks like a knife blade,
right.
but retained body there. I guess he got stabbed and the blade broke off inside him, either by accident or on purpose.
Right.
And I'm not sure whether that's above or below the diaphragm, or it's got to traverse it. So, you know, you can do a fast exam to make sure the pericardium's not filling up at this point. I think I'd probably do that. And if it's not, I think I'd get a CAT scan, since that's pretty long, that from the tip to the blunt edge. I think I'd probably get a CAT scan to see what's going on in the abdomen.
Okay, great. Thank you.
Thank you, Dr. Frisbee. Dr. Antrak?
Yes, I agree with that. I would get a CT to look for, you can evaluate all the areas that have been stabbed. Also, above the aortic arch on the left side, you know, just above the arch, it looks like an abnormal shadow, but a CAT scan would evaluate that. It's not an apical cap, but it doesn't look quite normal. But I agree with Dr. Frisbee. I would do a CT.
Okay. I'm going to stop sharing for 1 second. Sorry, guys, but keep going.
No problem. Dr. Colette, would you like to comment?
Yes, I agree with the comments. I agree with all the comments. I think in this case, you need to go to make patients stable. So you go to take a CT to see where is the tip of the blood, in this case. Sometimes I see people that have part of the blood in the chest. But here you can see this is above the diaphragm. So I believe it's very important to make a CT to see where is the blood, and then can decide if this thoracoabdominal injury in the tip of the blood is in the abdomen. You can go to a laparoscopy and take this out and suture the diaphragm. But at this moment, I believe this patient needs stable. He needs a CT.
Okay.
Thank you, Dr. Colette. Dr. Kasim, would you like to add any comment?
I agree with Dr. Frisbee, and I would do a ultrasound. I would do an ultrasound of the pericardium, a pericardial area, because that's the one that's going to kill him pretty quickly if he crashes. So I want to make sure that he doesn't have any hemopericardium. And then, since he has bilateral needle decompression of the chest, I might entertain the feasibility of putting chest tube on both sides. At least I would ask the staff in the emergency room to get ready in case we need to do that. So the next thing is, having done a chest X-ray, you look at the vital signs again to see if there is any change in the vital signs, such as continued hypotension or incipient hypotension. And I am curious about that blade in the left thoracoabdominal area. I have a feeling the knife went to the back of the diaphragm, and probably broke off. And part of it is in the abdomen, and the upper part it is in the chest. And it may have injured the spleen in doing so. and I would be concerned about that. So the next thing would be I would do a fast examination to the splenic area to make sure that there is no pooling of blood in this area, in that area. So all in all, he's pretty stable. There is nothing to rush about in this case, other than a methodical examination and evaluation to see what information you can ascertain from this, and then you can plan on what you want to do and to remedy the situation. Thank you.
Thank you, Dr. Kasim. Dr. Hoffman, do you have any comment?
No, I probably do exactly what Dr. Kasim said, do an ultrasound, make sure the pericardium is okay. And after that, this patient is stable. I will do a CT, I wouldn't do anything else. I would just like to remind everyone that the plain films are a single dimension and the patient has 3 dimensions. And I remember once when I was a medical student that somebody trying to play a joke to one of the surgeons put a cocker clamp on top of the abdomen and did an x-ray after that. And of course, this surgeon freaked out. But so we don't know. This can be in the skin. We don't know what it is. Patient is stable. Let's do a CT scan.
Thank you, Dr. Hoffman. Dr. Pereira, any comment?
Well, difficult to add something after all these comments. I just wanted to look in the right side of the neck, perhaps subcutaneous emphysema. And I would add a question, why was he decompressed? It doesn't seem to me that he has a large pneumothorax or something like that. Do you have any report on that?
I honestly have really no idea. Sometimes people, I mean, that's not a good answer, but sometimes people just come in needle decompressed. We didn't get a report that he had absent breath sounds or that he was in any respiratory distress en route. I don't know if it was because of the mechanism that they did that. But yeah, I thought that was a little bit aggressive for a pretty stable patient.
Well, the second thing is that well, all of us are worried about this blade, the knife here in the left upper quadrant, but I should remember that the patient has many stab wounds. You should not forget the others. So the fast exam is very important in pericardium, and let's see what happens. Thank you.
Thank you.
Thank you, Dr. Pereira. Any other comments?
Yeah, I'd like to know how old this guy is. How old is Victor?
He's 48.
Oh, okay. Thank you.
Can I just make a brief comment and a question?
Of course.
So it's interesting, you know, the night shift, as Jennifer pointed out, this patient, you know, came an hour before shift change. So the night shift felt exactly the same way like most of the commenters. You know, this guy is stable. He can get work up. There's no rush to take him to the operating room, and that's why he went to go on and has a CT scan. He will show in a minute. But the question I have for the group is, as you pointed out, you know, sometimes our EMS staff is pretty aggressive with needle decompressions in the field with people with penetrating trauma, and maybe he was a bit short of breath or something, I'm not sure. But if you have patients coming in with needle decompression, like this patient who has like 2 14-gauge IV catheters in each chest, would you now place chest tubes bilaterally before you go to CT scan, or would you not? And the reason why I asked this question is, you know, even within our group, there's some different opinions on that. And, you know, this specific patient, if I remember right, went to CAT scan without chest tubes, just with 2 angiograms, and it went to CT scan like this. We'll see. But the question for the panelist is, would you routinely put a chest tube or not? And this patient, as you can see, as you pointed out, there's a little bit of air in the right neck there. So it seems like that there's evidence of penetration, at least on the right side of the chest. Any thoughts on that?
Dr. Hoffman, would you like to make any comment?
Sure. No, I would not. We see this very frequently. They come with these needles and they don't get inside the chest. So I have a chest X-ray with no pneumothorax. Even if it went in, it didn't cause a pneumothorax. Initially I wouldn't put, and the patient who is stable, if the patient is unstable, it's a different story. Something I was noticing on the left side of the chest, a little bit above the line between the paper clip and the blade, appears to be something else, which could be part of the blade. Yeah, that's same. So I would be also extra careful because that's probably where the people would put the finger trying to put the chest tube. So the patient is stable. I would just go for the chest CT. The chances of him he didn't develop a tension pneumo by now. The chances of developing in the chest during the chest CT is probably very small, and I will be with the patient anyway, so I would not. Thank you.
Thank you, Dr. Antrak. Dr. Ochman, Dr. Antrak, any comment?
Yes, I agree with Dr. Hockman. You know, the EMS people say that their protocols require them to put those needle decompressions in the at the mid clavicular line anteriorly, and you know, ATLS has now put them laterally, but they usually don't go in the chest, especially muscular men when they're placed anteriorly. And that looks like a typical 14 gauge angiocath. It's probably not long enough. So, you know, I think it's good you probably left them see where they are on CT. But if they were in the chest and they were actually open, then, you know, they might have caused pneumothoraces, but they didn't. So I wouldn't put chest tubes now or do anything with those catheters before the CT.
Thank you, Dr. Antrak. Dr. Frisbee?
I'll leave them there. We'll find out where they are. If we didn't cause trouble, you know, if it didn't cause you any trouble, don't take them out and muddy the issue. Let's just find out from the CAT scan what we've got.
Thank you, Dr. Frisbee. Dr. Kasim?
If not, when it is not broken, don't have to meddle with it. Please, Dr. Frisbee.
Thank you. Dr. Collet, any comment?
I agree with all comments. I don't put chest tube in this patient. We say here is stable. I wait to do CT and see what's happened in the chest.
Thank you, Dr. Collet. Dr. Pereira?
Same opinion.
Perfect. Thank you. Dr. Puz, Dr. Lobb, go back to you.
Yeah, one more thing. Since everybody wants to go to CT scan, you're working in a 100-bed community hospital and the only CT scanner just broke down. So a quick question for the panelists. Which cavity you're going to enter first if you have no CT scan imaging available?
Dr. Pereira? Oh.
Well, nice question. Is it real? Is it real or just for discussion?
No, it's not real. It's just for educational reasons, because we have a little bit of time here. And let's say you're in a resource limited area where you don't have a CT scan, or the CT scan is down. You happen to be on a mission trip in Haiti and you have no CT scan. Which chest, where are you going to go?
Well, I think I would try a lateral plane X-ray. As Dr. I don't know who made this commentary, is we have these both planes, and sometimes the blade is in subcutaneous or in the wall, and I'll try to do a lateral film so to see if it really penetrated in the abdomen. If it penetrated the abdomen, I would try this first. Certainly a transdiaphragmatic pericardial window, and if the guys decompensate the thorax, perhaps the drainage. I'll do this.
Very good. Just to point out to the chat, Beth just put in there,
yes,
we have no CT scan in Malawi. So good question.
Very good. Any other comment, Dr. Frisbee?
Well, if you don't have a CT and you know, you can do your lateral x-ray if you want to, but if you're up against it, and I would do the fast, make sure that we don't have the abdomen filling up with blood. If you do, it's obvious you open the abdomen first. You open the cavity that's going to kill him first, and that's going to be this. But that's my only comment.
Thank you, Dr. Frisbee. Dr. Antrak?
Yes, I agree with that. Assuming that you're in a place where there is ultrasound, I would do the fast, and then you'd be able to actually see the cavity where it'd be hard if it was in the lung, but if it's in the abdomen, you should be able to see it. There'd be bright echoes off the blade, and you'd be able to see if there are injuries to the surrounding organs. And I would, and if it were in the abdomen, then I would do a laparotomy. And I assume that if in that case you didn't have if you don't have a CT scan, you don't have laparoscopy, and I would do a laparotomy. If you don't have CT scan in a developing country, the scalpel is the CT scan.
Mm-hmm.
Thank you, Dr. Antrak. Dr. Ochman?
I always say that the beauty of this conference is that force us to think in many different ways, and we find surgeons with much less resources solving the same problem, and we all learn from that. So if you don't have a CT scan, I would probably just a lateral view with the X-ray, which obviously you have because you were able to get this done. I would be a little bit cautious about using the ultrasound in this case because it's the interface between the lung and the abdomen, and the visualization there, if it's below the diaphragm, yes, you can see. It's above the diaphragm, you cannot see very well. Yes. And also it could be in the retroperitoneum, and where I would probably not go fishing for it unless it's causing trouble. So I would like to get more information before committing. If the guy is bleeding, yes, of course, has a negative FAS, or even if I don't have an ultrasound, I will do a pericardial window and open the abdomen in that order. Otherwise, I will do everything possible to get more information. Thank you.
Thank you, Dr. Ochman. Dr. Kasim, any comments?
Well, if CT scan is not available, and if laparoscopy is available, that would be a simple procedure to do, like Dr. Collet mentioned. And you could do a laparoscopy to see if the peritoneal cavity has been violated. And if CT scan as well as laparoscopy is not available, just observe the patient for a little longer. You don't have to rush this patient to the operating room till he tells you what is wrong with him. You know, you don't have to gung-ho go to the operating room and think about whether you're going to the chest or abdomen. Just observe for a while and see, you know, if he becomes hypotensive, check his blood and repeat the chest x-ray and do a clinical examination of the abdomen. And there's nothing wrong with that. So that's what I would do.
Thank you, Dr. Kasim. Dr. Collet, would you like to comment?
Yes, I agree of all the comments. When you don't have CT available, probably you don't have laparoscopy too. So in this situation, I think the most important is patient is stable, he has signs of peritonitis or not, and then if there is, sometimes I can wait to make a CT on another day or in another hospital, transfer the patient, or in any situation, I go to a laparotomy if there is evidence of violation of abdominal cavity. So in the chest, I will just wait. Okay, but in the abdominal cavity, I think it's very important to see if there is some signs of peritonitis or signs of bleeding, because it's lateral. You can remember the spleen is near of or when maybe the tip of the knife that's in the abdomen of the patient. So I think it's very important to see go to a laparotomy. I remember when you don't have laparoscopy or CT scan, probably you don't have laparoscopy or VAST, so you can go to a surgery procedure. Thank you.
Thank you, Dr. Collet. Anyone else? Any comment? We go back to you, Dr. Lobb.
All right. Thanks, everyone, for your comments. So it seems like we polled people, and it seems like most people would go to the CT scanner if it's available to get more information. And that's exactly what was done. This is the scalp film of the CT, so you can see the location of the knife blade here on the initial scout. So fortunately, actually, the needles they made it quite a bit into the chest cavity. I know we were talking about, he was quite a thin male. He did have a little bit of a pneumothorax on the left. I'm just showing the pneumo on this CT. And then this is the CT scan, really, which is showing the location of the foreign body, the knife blade. So it's really unclear still whether it is in the chest or in the abdomen. They did place a pigtail on the left side because of the pneumothorax that I showed you on CT after the CT read came back. And this happened about 7:30 in the morning. And then, you know, we were in our handout at 8 a.m. and we were discussing this case. So this was Dr. Poos and I looking at all these images, and just as you have in this presentation. And now we have to decide how to proceed. So I just want to poll the audience now and see what you would consider doing next. Next.
Dr. Pereira, would you like to come?
Dr. Lobb, could you please show us the X-ray again?
Of course.
You said the pigtails on the left side. I believe it is right side. Left side show.
Yes, I'm sorry. Right and left.
Yeah. And the right side you got a drain,
don't
you? Yeah, kind of 36.
This is not. Sorry, this is not the right. This is not the right chest X-ray, and I apologize. There was just a pigtail that was placed on the left side in the recess bay. So he has a left-sided pigtail for this CT scan finding, and no other interventions. And we came in about 8 a.m. and found this guy sitting in the ER with a left-sided pigtail in place, totally hemodynamically stable, no respiratory distress, no complaints.
And about the CAT scan, I can see clearly the stab, the wound. Sorry, the knife, the blades go through the thorax. I believe goes through the thorax and perhaps to the abdomen. So I would start with a VATS, video thoracoscopy, and try to find out if the blade goes through the diaphragm. Then if it's possible, if it happens, I would do a laparoscopy, but I would start with thorax.
Okay.
Thank you.
Thank you, Dr. Pereira. Dr. Ochman?
Well, the thing that you have to be concerned based on the location is a diaphragmatic injury. And in that area, you have to repair it. So I would go you can go both ways. Usually, when I have a diaphragmatic injury, I prefer to go with thoracoscopy. Having said that, because of the location on this one, it looked like it will be much easier to do via laparoscopy. And so I would probably do this via laparoscopy with the chance of entering the chest to remove the foreign body from the chest if I can.
Right.
And repair the diaphragm from the abdomen, and also exploring the abdomen, make sure the stomach, nothing else has an injury from this knife. I would probably repair with this new PDS that have like spikes, the barb PDS.
And the locking.
Yeah, locking PDS. That's what we normally use for things like that, 1 or 2 stitches to close. I would probably wouldn't put the pigtail before the surgery, although probably he will end up with a chest tube. And the fact that by protocol, the paramedics put the needle decompression, even though the patient didn't need that, proof something I always kind of joke about, but it's very true. Unnecessary procedures have 100% complication rate. So they probably shouldn't do that blindly if it's not indicated. But that would be my approach. Thanks.
Thank you.
Thank you, Dr. Ochman. Dr. Antrak?
Yes, it looks like on the left that catheter went right into the lung. I mean,
I know, right? I was like,
so
wow, guys.
that didn't do any good. I mean, but
necessary procedures, 100% complication rate.
Yeah, exactly.
Yeah, exactly. So when you pull that out, probably that's going to make the lung collapse. So I'd be careful, but be ready to put a chest tube in. But anyway, or I guess they put the pigtail.
Yeah, he had the pigtail placed.
That last image that you showed, I think probably if you you can find the broken part of the blade through the wound, the stab wound in the chest wall between those two ribs, and so I think I would explore the wound and see just locally, and you'd find the end of the blade, just remove it. And then I agree with Dr. Hochman that probably it's easier to examine the diaphragm through laparoscopy. You can mobilize the left lobe of the liver and then see the area where the blade came through, and then it's probably easier to put the stitches laparoscopically from through the laparoscope rather than thoracoscopically. But and at the same time, you can inspect all the surrounding organs to look for injuries from the blade. But I think just looking at that adjacent wound where he was stabbed, I guess right at the anterior axillary line on the left side, and then see if you can feel the blade in the wound with a Kelly forceps, Kelly clamp, and try to remove it that way.
Thank you, Dr. Antrak. Dr. Kasim?
Just a quick comment to the panelists, because we only have, she only shows one slide. We're pretty confident when you look at multiple slides of the CT scan that the blade is in the pleural cavity and not below the diaphragm. If you look at all the reconstructions, and because it's hard to see from just this one slide. Right. So we were pretty confident that this blade is in the pleural cavity and not below the diaphragm, just to point that out.
Dr. Kasim, would you like to comment?
That's precisely what I was going to say, that there is some doubt here exactly where this track is, whether it is going into the pleural cavity or the peritoneal cavity. And as Dr. Untrak mentioned, that if you want to do a local exploration, and remember the patient is very stable, you're not going to do any harm to this patient, but you may do quite a bit of harm by doing something that is not totally necessary, like Dr. Hoffman has pointed out, because unnecessary stuff produces 100% complication. So keeping that in mind, if you are not sure what you're dealing with here, so go ahead and remove the foreign body that you think it is either going into the pleural cavity or peritoneal cavity, and follow it with a little catheter, a sterile catheter, and put some contrast in, and you will know exactly where you are, whether you are in the pleural cavity or peritoneal cavity. And then you can make a decision what you want to do. That would be another way of dealing with it without resorting to a big surgery where it may not be necessary for this particular patient who is very stable. Thank you.
Thank you, Dr. Kasim. Any other comments? I see that there is a question from Dr. Tooney, and he's asking if the forgiven body is no longer there, I guess, for Dr. Lobb.
If the foreign body is no longer there?
Yeah, he said that.
Oh, no, it's definitely present, and I'll show. Yeah, that part's coming up. Sorry, Tony, I don't want to ruin the whole presentation.
I do have one comment regarding the placement of the needle in this particular case. Jennifer, what was the indication by the EMT to place the needle? Was the patient hemodynamically unstable, or was the patient being transported via helicopter in a long transport?
So, Dr. Ruiz, that's a great question. I think you may have joined us a little bit late because someone from the panel actually asked that question. And as I had said before, we don't know. The guy, he did not come via helicopter, and I don't know whether he was, in respiratory distress. There really wasn't anything reported in the notes that I reviewed as to why those bilateral needle decompressions were performed. We were talking about the fact that it seemed a bit aggressive considering that the patient was totally stable. But unfortunately, that's just what he arrived with.
Thank you, Jennifer. I apologize for the repeated question.
No, it's okay.
In reality, sometimes we see that the EMTs have kind of equated the presence of the clinical presence of pneumothorax with placement of needles. And this is something that I've been working for a couple of years now, trying to figure out when the miscommunication started. Because now in their protocols, there's this kind of belief that if there's any pneumothorax whatsoever, a needle should be placed, but in reality, it should be only for the relief of tension pneumothorax or in patients in which transport is difficult, namely the helicopter, in which they don't have access to interventions. But thank you again. Incredible presentation.
Oh, thank you, Dr. Reese. Okay, any more comments before I move on? Okay. So we had a lot of comments from the panelists about what you would do next. As Dr. Poos mentioned, when we first saw the x-ray and we saw, part of the CT scan, we were very confused too as to the location of where the foreign body is. But after we reviewed everything in depth, we decided that we were fairly confident that it was in the chest. And the interesting thing is that we talked to the patient about, a need for not an emergency surgery, but an urgent surgery. And he was so stable, he actually did not want to have surgery. He tried to refuse initially, and Dr. Poos and I counseled him about, the fact that he has a foreign body in his chest and that we need to take it out. So we consented him for a VATS possible thoracotomy. And I will say, just to give a shout out to Dr. Poos for this case, me as a trauma fellow and like a new attending coming up in the next couple of years, I definitely don't think I would have tried this via VATS because I think what we ended up doing was too difficult. But Dr. Poos wanted to start thoracoscopically, and that's what we did. So you can see the patient positioning here in the OR. This is actually one of the stab wounds, the left chest axillary stab wound. I don't have the other ones. You can't really see those in the picture, but this is the, and then here you can see at the top, we left the catheter in place. So it is there. So we started by positioning in the right lateral decubitus, but, just kind of a mini right lateral decubitus to expose the left side. These are just some pictures of, I had some videos, but due to the internet connection, I didn't want to overload everyone's, internet connection. But basically, what we ended up doing, and I have a couple of pictures here. This is the knife blade here on the left side of the screen, and this is a peanut, like a laparoscopic peanut, and I'm actually have the peanut compressing against the pericardium. Because this is the pericardium right here. So we found the knife blade, actually, it was maybe 0.5 centimeters away from the pericardium. And there's actually, you can see here, a very superficial laceration in the pericardium from the knife blade. And then here on the left side of the screen, you can see where Dr. Poos actually has a portion of the knife blade with the laparoscope, with the forceps, like a bowel grasper. And he is, pulling that, attempting to extract it via, a small, it would really be more of a hand assisted VATS, but through a small mini thoracotomy incision. So these are just some more pictures, and you can really see how close the knife blade was to the pericardium and the superficial laceration. You can see some more. These are further pictures here that you can see. I don't have any pictures of the diaphragm, but actually we examined the diaphragm and there was no diaphragm violation in spite of what it looked like on the CT scan. So that was quite interesting because I was expecting, there to be some sort of diaphragm laceration, but we examined the diaphragm and it was okay. In the end, this is the foreign body that we ended up retrieving from the chest. This was done through a VATS with a hand-assisted VATS. We just opened one of the incisions a little bit larger so we could actually fit the knife blade out. But here you can see it's with a ruler measured for size. So I just wanted to, and we talked a lot about this already. Everyone brought up good points. A lot of people thought that there was a diaphragm injury. So we really talked about, how you would proceed if there was evidence of a diaphragm injury. But we wanted to expand this. We were lucky, the patient was very lucky that the pericardium was just barely nicked superficially with this knife blade. But was interested in learning or knowing how everyone would proceed if you found that, the pericardium was violated and there was blood in the pericardium, how you would proceed with the surgery at that point.
Before we go to this question, you know what was interesting? When we put the camera in, you literally saw like the heart and the pericardium bouncing against the sharp edge of the knife. And, you know, you look back and you think like, you know, for the last 2 hours, that pericardium has been bouncing against the knife blade. And, you know, we all think like, ah, yeah, you know, this patient is so stable. We have plenty of time to do workup and stuff. But when you see it, how the heart is beating against the knife blade, it's pretty impressive. Now, it's not fixed, right? It's freely floating. So the likelihood that it's going to stab through is probably small. But, you know, we did saw some partial laceration of the pericardium, but it wasn't full thickness through. The interesting thing, that's why we were, you know, using the pina to move the pericardium and the heart away a little bit from the blade before we grabbed it. You know, the interesting part comes the moment you grab it with your grasper, right? Because now it becomes a fixed object, and the heart, you know, the movement of the heart, it's beating against that blade. So that's the difficult part, or the critical part, where you have to be careful that the moment you grab it and you fix it in your laparoscopic grasper, that you then don't basically, you know, at that point stab the heart with the knife. So I think we have to be careful that we don't cause an injury at that moment. That's why we were using the pina to kind of push the heart away from it before we grabbed it. And then we put a Cali clamp through the actually stab-on incision and passed it over with a laparoscopic grasper into the Cali clamp, and then pulled it out through the same injury, through the same incision the knife went actually in. So that worked okay. But you know, that's one thing to consider. I'm curious what the panelists think about the fact that, you know, the heart was actually rubbing against that blade the whole 2 hours we were doing all this workup. If you see any concerns about that. And then go ahead and we look at this question, what you had up there, the next slide.
Would you like to go for comments, Dr. Lobb?
Yes, please.
Okay, Dr. Kasim, your comments, please.
Well, my comment is, you know, if the patient would have had violation of the pericardium, there will be a telltale sign of that, one way or the other, and then you would have ended up in the operating room quickly, rather quickly, I would say, for a median stenotomy. You know, you would have been hypotensive, tachycardic, and jugular venous pressure. He'll have a Beck's triad if he's one of those guys whose Beck's triad has become positive. And so you will get to the patient very quickly, the operating room, do a median stenotomy, and then you'll take care of it, hopefully. And but what it tells me is, whatever injury this was, it was not really causing any patient to any problem. You know, it just missed everything. Just like sometimes, you know, you have a gunshot wound, it just goes, it takes a little bit of either a piece of bowel or a piece of blood vessel, but doesn't cause any problem. You know, and you see it and you say, oh, lucky, then put a couple of switches and you get out and go for coffee. So I think the lesson here is really, in a very stable patient, you do have the luxury of time to find out what you're dealing with and how you're going to fix it. I would not have done VATS on this patient. You know, first of all, I'm not very good at VATS because VATS came on long after my training. I would have done a mini thoracotomy as I was taught by the famous
and other
surgeon.
people here, Dr. Kasim, it sounds like you.
Can you hear me?
Yes, we can hear you, Dr. Kasim, yes.
Oh, okay. I think I would have done a mini thoracotomy as I was taught by the surgeon in Brompton Hospital in London. Works for me very well, and I can get in very quickly. I put my whole hand in. I think Dr. Cooley used to do the same thing as well. But of course, Dr. Boots is very good with laparoscopy. So is Dr. Collet. Those two gentlemen can do this with the laparoscope and with impunity. And I take my hat off to them. Thank you.
Thank you, Dr. Kasim. Dr. Antrak?
Yeah, so it looks like, everyone was so confident how stable he is, but, he was one vigorous cough away from a sudden death, and that would have been really embarrassing. So, geez, I mean, I would have seen that image and after having been cocky and say how stable he was, if he were my patient, and put it off and say, gee whiz, did I get away with something here, but so it's pretty scary. And then if he was felt stable, didn't want to have an operation, I would have just shown him the chest x-ray. Say, see that knife in there that, it's going to move. But so and it's a good lesson that if you go in to fish out a foreign body, had I done what I suggested, I think it's okay if it's there, and you can grab it and pull it out without pushing it further in. That might work. But through the thoracoscope, I think I don't know if it would have made a difference if you would have grabbed the blade closer to the tip and then pull it back and rotate the point away from the pericardium, and if that might have been safer. But what you did worked, so that was fine. And it's possible that the CT, there wouldn't have been blood in the pericardium because the knife hadn't poked the heart yet. But if there were blood in the pericardium, I suppose I would just open it, look, suction it out, irrigate, inspect the surface of the heart, and if there's a trivial injury that doesn't need to be treated, then just make sure it stops bleeding, apply some pressure. If there is an injury to the diaphragm, then I think it should be easy enough to put some sutures in through the thoracoscope. Mediastinal injury depends on what type. If it's in the if it's posteriorly in the esophagus, well, you just have to deal with esophagus or aorta, or anteriorly in that area. I think there wouldn't be much other than the heart. But anyway, it's enough to really, it should send chills down your spine when you see where the knife was and how you got lucky in that case. It would have been very embarrassing if he just came in stable, coughed, and sudden death, and you had to present this case at M&M. So, geez.
Dr. Untrak, one question. The pericardium is a fibrous tissue. You have done hundreds of pericardiotomy, like I have done as well. You actually have to take the scissors and cut it to open the pericardium.
Yes,
this particular knife wouldn't have done that.
Oh, it wouldn't have, no, but if there were blood in the pericardium, I guess the presumption was that the blade had punctured the pericardium and, and damaged the heart. There was bleeding, but, I suppose, if the point is right there, like any stab, but you might be right. Maybe the likelihood that it was gonna just a fractured blade with no one pushing on it would not have done that. Maybe you weren't so lucky that's the way it is. It wouldn't have caused damage. But I wouldn't have been so confident after I saw the picture through the thoracoscope, and I would have considered myself very lucky.
Yes.
Thank you, Dr. Untrak. Dr. Frisby?
I think Dr. Poos had every right to be really worried once he put that, stabilized that foreign body, because now you've got a stable, very sharp object bumping up against a moving, every second of the day, the pericardium is now impacting on that sharp edge. Before this, you had a foreign object that was sort of flopping there in the breeze, moving to and fro with the heartbeat. But the moment you put a clamp on it, it becomes a knife. I mean, it becomes a slicer. You might as well be in the deli. So at that point, you need to get that baby out of there. And to Kasim's comment, I'm old enough to know my limitations. I couldn't do it through the VATS. I couldn't use it, and I would have to do a mini thoracotomy and just put the heart muscle and see if I couldn't back the object out the way it came. At that point, to the point though, I think you did a great job. How did you get that thing out of there without it slicing into the pericardium once you put the clamp on it? Did you just push it back the way it came?
Yeah, I mean, you're absolutely right. The moment we put the camera in, my sphincter muscle got really tight, because, it's really like, you look at the CAT scan, it's like, yeah, it's pretty close to the heart, but obviously there's no evidence of cardiac injury. But, the moment you look at the camera and you see how the pericardium is bouncing against the blade, and now you want to grab it, you pause for a moment and you think like, is this really the right approach to go for it? Or should we, not do it laparoscopically and open him, right? But we used the peanut to move the heart, just push it away a little bit from the blade. So we had some safety area there basically before.
Well, to your great good, you did a really smart thing. You took that berry, cherry, or whatever you want to call them,
yeah,
and pushed. And kept it away while you were in smart move. I think really well done.
You broke up a little bit, yeah, but exactly that's what we did. So before we grabbed it, we used the peanut to just push the heart away a little bit with the pericardium. Before we grabbed it, to create some space in between. And because of the size of the knife blade, we knew we wouldn't be able to get it through the trocar. So through the injury, just as Dr. Kassim mentioned, we would just, extend the incision where the stab one was. We extended that a little bit to like an inch and passed the cali clamp through the injury and handed it over, with a laparoscopic grasper to the cali clamp and then pulled it through the injury site, which we just had extended a little bit. So we didn't have to put it through the trocar because I was worried, we put it through the trocar, it's going to fall off again, you're going to lose it and so on. So we handed kind of over basically.
Nicely done. That's all my only comment.
The question I have is like, let's say you find an injury to the diaphragm, okay? Do you guys feel obligated to do a laparoscopy now? Because obviously there could be a concern of that you have a gastric injury or a bowel injury. If you're in the chest now, you're looking at the diaphragm, you could repair it from the chest, but how do you rule out intra-abdominal injury? Would you just observe him to see abdominal examinations, or would you go ahead, since you have him on the table, and perform also laparoscopy to look at the stomach and the colon from the abdominal side?
Dr. Pereira, would you like a comment?
Well, I'll do a laparoscopy, but I'd like to start showing that this case was a perfect example that you should always try to retrieve these foreign bodies, these impaled objects under direct view. Most of them, they just don't really do a major injury when they get in, but when they get out. So if you try to pull them out without seeing what you are doing, you could increase the injury and perhaps in this case could kill the patient. So congratulations on that. It's a very good case. I'll do a laparoscopy. If you got a poke or a small tear in the diaphragm, just a laparoscopy and can examine all around and see if there is any injury less. Thanks.
Thank you, Dr. Pereira. Dr. Ochen?
This conference are a lesson for us to being humble. Let's put it that way. We always get surprised. We always assume something, and after that, it's something completely different. How to approach this if the pericardium is violated and there's blood in the pericardium. And I always use as an example something that happened to me a day after we have this conference. It was like 7 years ago. Was a discussion during this conference. So you approach this type of things through a median sternotomy or an anterolateral thoracotomy. And at that meeting, I say, I always do median sternotomy. I think lateral thoracotomy is a very bad incision, doesn't give me good exposure, blah, 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 blah. That same night, the same night that I said this, I have a patient with a stab wound to the parasternal area. We have a T, no heart injury, whatever. I say, okay, fine, I will do an anterolateral thoracotomy. The same night that I say that I wouldn't do them. And I did it. and it was a heart injury, and I had to do a clamshell incision when so I am not dogmatic. I try not to be. I was thinking at that time I wasn't being dogmatic, but obviously I was. So this, I will do whatever appears to be the best option. You have the patient probably in a lateral decubitus. You will have to move to do a median sternotomy. So probably thoracotomy will give you good exposure. You might need to extend that if it's needed to evaluate the pericardium. If it was an injury to the heart, it will be at the apex of the heart. So it will be easily accessible through that incision. I still think that the anterolateral thoracotomy doesn't give you good access to the heart, or maybe it's me only, and better surgeons can get access to 95% of the injuries of the heart. Every time I did the anterolateral thoracotomy, I ended up doing a clamshell incision. I don't think I ever solved anything through an anterolateral thoracotomy, but here will be more like a lateral thoracotomy. I think that you can do it that way. If it's a diaphragmatic injury, and only the diaphragmatic injury and the pericardium is intact, I will probably just observe the patient because there was nothing on the CT. I will close the diaphragm from above and see what happened. But again, I would hate to be dogmatic on this thing because there is not enough literature to say go one way or another. We are all going based on personal experience. And definitely it can be somebody with much experience that I have. And I am going to send a link to a video that I always use for joking, and go 30 seconds into this video and you will understand also why we need to be humble in this type of cases. Congratulations, Dr. Proust. This was handled perfectly. Tip of the hat to you. Thank you.
Thank you, Dr. Rochman. Anyone else would like to add any comments? Then we go back to you, Dr. Lobb.
All right. Yeah, I'll go through the rest quickly. There's not much else to talk about because fortunately the patient did very well after this. This is our picture at the end of our surgery. You can see that we inserted an angle chest tube and we closed the incisions with staples. He had his, serial chest x-rays. He was admitted to the floor post-operatively. He had no issues on post-op day 2. The pigtail was removed. This is the follow-up x-ray. And then he actually had his surgical chest tube that was placed removed on post-op day 3. And then this was his chest x-ray on post-op day 5. He was discharged home and he was seen in clinic a week after that, and he didn't have any new complaints and the staples were removed. And since that time, he's not been back to the hospital, to my knowledge, for any complications from this. So that is all I have. It was really about the initial workup and management. But thank you so much, everyone, for your comments, and I'll take any additional questions or comments that anyone has.
No, I'd say just an interesting case, and and I think it's a good teaching case to be. We shouldn't be so sure before we have the final answer. Always be a little cautious, and and in this case it worked out. I hope this gentleman, that's his last experience with the trauma team at Miami, or anywhere else. But very, very nice case. Thank you.
Thank you.
Thank you, Dr. Antrag. Dr. Frisby, any comment?
Yeah, really. They used to tell us that knife wounds are really, really problematic. You think they're going to go one way, they go the other, and whatever they don't hit, they hit something else. But to tell you the truth, this was really well done. I can't use the VATS because I don't have the skill to do it. But I think the case was really well managed, well done. Nice case.
Thank you, Dr. Frisby. And Dr. Pereira, your comment?
I would like to it's a nice and teaching case. I learned a lot, and thank you very much for sharing. Very good opportunity. Thank you very much. Congratulations.
Thank you.
Thank you, Dr. Pereira. Dr. Kasim?
I think it is very much dependent on your comfort level, what modality of treatment you want to observe when you see something like this. Some of us will go for thoracotomy, and others, like Dr. Pooch and Dr. Collet, they will deploy thoracoscopy, and because they are very good at it. And unfortunately, I trained in the earlier period before thoracoscopy came into evolution, and I never really pursued the art of thoracoscopy like I should have 10 years, 20 years ago, but I didn't. I kept to my specialty of thoracic surgery like I was trained many years ago. But if you are good at it and if you are comfortable, this is the way to go. You know, I think the newer generation of thoracic surgeons, they're all very good at thoracoscopy, VAT, and lobectomies and things like that. So I think the open thoracic surgery will become a thing of the past, in my opinion, unless you want to do a pneumonectomy or something like that. Very well done, well thought out by Dr. Pooch. He thought about it and institute what he felt comfortable with and accomplished what he wanted to do and save the patient from a disaster. Thank you.
Thank you, Dr. Kasim. Dr. Ochman? Oh, sorry.
The only thing I had to say that this was a humbling experience because we all were making assumptions that at the end were incorrect, and try not to be like the surgeon in the video that I sent, because you are better by being humble. And I remember an old aphorism: a physician without a doubt is a physician without experience. And I think we also should be mindful of that, not to be, there is nothing certain except death and taxes. Thanks.
Thank you, everybody, so much for the kind comments. I tell you, the greeting in the morning from the night surgeon was like, "Hey, I have a great case for you. I wish I could stay and do it, but I have to go around on my service." But I tell you, I rather do open surgery and thoracotomy. And I thought back myself, the patient would have come back into the trauma bay, and I was on the moment he rolled in. I'm not so sure if I would have done a CAT scan and stuff, if I would have just taken him to the OR and explore. And I was probably wrong about it because the CT scan really give us a lot of information in which cavity the knife blade was. So we knew from the CAT scan which cavity to go, which we wouldn't have been otherwise. Right? If I would have taken straight to the OR, I probably would have ended up, doing a laparotomy or laparoscopy on pericardial window first, and would have realized that the blade is in the chest, and now I have to go to the chest. So the CT scan really showed us which cavity to go. But when I put the camera in and I saw how the knife blade was riding, on the pericardium, I was like, whoa, I was like, I'm not so sure I would say I was in my comfort zone, because people say, oh, you're all comfortable, doing laparoscopy or VATS. When we usually do VATS, right? We do VATS to evacuate hematomas or empyema or something. We don't do, as trauma surgeons, a lot of like technical operations laparoscopically in the chest, right? I've seen a video from somebody who repaired a heart laparoscopically, a stab onto the heart. They just opened the pericardium and sutured the heart laparoscopically. I can tell you, I for sure would have opened, if I would have found a cardiac injury, for sure would have not even, think about continuing doing anything laparoscopically. But I tell you, I was like, we're pushing it here, and I was like, it's much easier to operate, to do a thoracotomy on somebody who comes in with a blood pressure of 60, you know what to do, right? It's very simple, right? It's the one patients who have come in, seem to be very stable, and you start to overthink things, right? You say, we could do this, we could do this, and we could do this, and 2 hours go by, and then you look at it and you think like, wow, this knife blade has been riding right next to the heart all the time. But I agree with Dr. Kasim, as long as it's free, it's probably not going to do anything, right? It's not going to do anything, but now we're turning it into a fixed object, and it's a whole different story. So I was stressed in this case more than for most of the open thoracotomy cases I would normally do. I tell you that, to be honest. We got lucky.
No, you are good. You're good.
We have to be careful, right? I mean, of course, we decrease the morbidity significantly, right? You do a full thoracotomy on the patient for a little stab wound like that, we would give them a significant morbidity. On the flip side, if we would have caused a cardiac injury, we would have caused much more harm than the thoracotomy would have done. So we always have to keep in mind how far we're really going to push it. And if in doubt, I think it's always better to rather convert early to open than trying to push it too far. So as you know, as Dr. Hutchins say, be humbled.
All right, thank you, Dr. Lobb and Dr. Post. Thank you very much, Dr. Stubing, for joining us from Malawi. We hope to see you next week.
There's a prepared mind. Don't worry about it.
Thank you very much, everyone. Have a good day.